I'm going to ask Dr. Black and Dr. North to come up and join Linda, and we're going to do our panel question and answer. And our moderator today is going to be Joan Basiak. Joan is our Director of Medical Relations for Kidney Cancer Canada and outgoing Chair of Operations. So, Joan, the podium is yours to go through some of the questions that we've had from the folks in attendance today.
I'm short, but not that short. Okay, so we've got lots of questions here. The first thing I want to say is, thank you so much for putting in your questions. It's a great way for us to get some more information from our medical experts. We've only got limited time, so I'm going to do my best to get through as many as I possibly can. There have been some that have come in that I think are going to be addressed by other speakers that are coming in the afternoon, so I'm just sort of holding those off. So if your question isn't answered, it's not a reflection of a poor question. It's a reflection of either time or it's, might possibly be answered as we move forward. Okay, so not in any particular order. So this one's coming through for both Dr. North and Dr. Black. The kidney with the tumor has been removed, and now there's 2 new tumors that have grown back at a spot of a lymph node. Why can't surgery be done, and what else can be done? Dr. Black can go first.
Well, that's a very specific question, and it depends where those lymph nodes are and the size and what they're close to and that type of thing. They might be able to be removed. It depends. So I'd have to see a CT scan to answer that question.
It's often a fact that a lymph node is a filtering device, and if the cancer is going to leave the kidney and travel through the lymphatic system, it eventually, if it does that, might be in a lymph node and grow over time. And one of the problems is, as Dr. Black mentioned, if that lymph node is a little bit further removed from where the kidney used to be, what that is telling you is that perhaps those were cancer cells that had escaped the kidney, and that's just the first spot of many others that might develop with more time, because once it starts to travel, it could travel everywhere. And I think of cancer cells when I'm talking to patients, individual cells by themselves are like crystals of salt, and you need to have enough of them in one spot to see them. So if you had a whole tablespoon of salt, it's kind of apropos, and you dropped it on the ground in one spot, you could see it because they're all there. But if you took that same tablespoon of salt and sprinkled it over your entire backyard, you'd never find the individual crystals. So sometimes these things pop up because they just given enough time, show up as the tablespoon of salt. If you keep trying to go and operate on those, you're simply going to be having an individual who has multiple operations, and it's a marker that perhaps this is actually a total body problem, and that might be more of an indication where you might think about drug therapy, which you'll hear about later today.
Okay. Question for Linda. Linda, the question is, would the diabetic diet be a good one to follow for kidney health? And this particular question came from a patient who is considered pre-diabetic.
I think if you, and I'm not quite sure what they mean pre-diabetic, I would just assume that they are heading towards the diabetes stage. And I would say a diabetic diet would be good. Especially if you're with a kidney care diabetes team, it would be good to follow because they always recommend a balanced diet. And I think that would be a good way to start, okay? Because it would be very similar to Canada's food guide too. So, and it would be balanced, and at that time they would be watching their blood sugars. So could be a good place to start.
Okay, thank you.
But I might add further along, if there are issues with potassium and phosphorus, then there would be adjustments.
Okay. Dr. North, how do you identify that a cancer has metastasized and is not a new cancer?
So it's an excellent question, and oftentimes what we look at is what the pattern of where these new spots might be that show up. So typically when a cancer is metastasizing, it's because it gained access to the circulation, whether that be the bloodstream or the lymphatic stream. And there may be many different cells, hundreds of cells, thousands of cells that are all traveling at the same time that might be setting up a secondary metastasis at a distant location. So often what you see when somebody has metastatic cancer is it's not a solitary or single spot that has popped up on those follow-up scans that determine that the cancer has recurred. It might be that you do a CAT scan and you identify a half a dozen spots in the lung or a new series of lymph nodes in the abdomen. And that would be very different than perhaps a new solitary spot in the remaining kidney tissue that you might wonder whether or not that was a brand new cancer. So it's often the pattern of spread that we see it coming up in other parts of the body, not the organ where it originated. And you'll often see multiple different of these spots at one time, not just a solitary spot. Sometimes, though, we do struggle and we don't know for sure. And in those cases, we may have to go back and look at more testing or biopsies or so forth to determine.
Okay, Dr. Black, this is a very personal question for him. Okay, so what percentage of your nephrectomies are partial in your practice?
Well, that is a difficult question. So, you know, at Vancouver General, of course, a lot is based on referral patterns. So I am referred patients specifically for partial nephrectomy, or I'm referred specifically patients with, for example, extension of the tumor into the lymph nodes or into the vena cava, the big vein that goes back to the heart. So I see sort of both extremes and not a lot in the middle. So partial nephrectomies are probably 75% of what I do.
Okay. And how many of your partials have you then had to proceed on to a total nephrectomy due to some complication that occurred during the surgery?
0.
Dr. North, what is the rate of a false positive diagnosis of renal cell carcinoma?
It's hard to come up with a number off the top of my head, and you know, Dr. Black had commented on the fact that sometimes you see a significant percentage of these small renal masses which are actually benign, and that's why they're followed. Once you're starting to get into a lesion on a CAT scan that's greater than 5, 6, 7 centimeters, they're almost always malignant, and that's one of the reasons why people have often foregone the biopsy and headed directly to surgery, because the chances that that could be something that is completely benign are very, very low. It's when you have those very small masses below 4 centimeters that the rates of false positive, in terms of just looking at a scan and saying malignancy, could be in the 30-40% range, and they're often biopsied or followed.
Okay. So this is sort of for all of the speakers. The question is potassium level that's very high. Why does that occur, and why is it important to lower it?
Often in my practice, I see potassium is elevated possibly because the kidney function is not as good as it used to be, so it's harder for us to excrete it in the urine. Sometimes, or often, a lot of our patients are given medications that will raise the potassium level, and those medications are very important for preserving kidney function and to manage diabetes, high blood pressure, and so therefore that would raise the potassium, and we do see that, yes. And then we would make modifications, especially to the diet.
So the challenge is that the primary way that we get rid of potassium is through our urine. And if your renal function is declining for any number of reasons, not just because you have surgery, but maybe it's chronic renal insufficiency because you're a diabetic or some acute event has happened, you can't then pee it out. And as potassium levels rise higher and higher, the biggest threat that they cause for us is to our heart. They can actually cause abnormal heart rhythms, and that can actually be life-threatening if the potassium level goes very, very high. And if we see that on blood work, there are medications that we can give in the very short term to try to stabilize the situation and get it under control. But then you have to look at the whole patient picture to figure out why that happened and what you can do to prevent it from happening again.
Thank you. Dr. Black, you spoke in your presentation about EGFR. If in a patient it's less than 60 what can that patient do to reduce their cardiovascular risk?
That's a great question. So you can't do very much to change your EGFR other than avoiding things that will make it worse over time. So avoiding high blood pressure, or if you have high blood pressure, treating it, avoiding diabetes, or if you have it, to treat it. But otherwise, the main means we have to avoid cardiovascular problems are, of course, healthy diet and exercise. And so I tell every patient, whether it's kidney, bladder, prostate cancer, is always, this is an opportunity. It's a teaching moment to, think about your lifestyle, adjust your diet, and start exercising if you're not already.
Okay, thanks. A question for Dr. North that comes up with your talk. Is it true that we got cancer from the food that we take, that we eat?
Sorry, could you just repeat?
Is it true that we get our cancer from the food that we eat?
So it's a good question, because we are all concerned about what's in the stores, what's on that food that we're buying. What this comes down to, again, is what is it in our lives that causes that imbalance between those tumor suppressor genes that keep the brakes on and the opposite, which is called an oncogene, which makes things grow. And we know that one of the causations of cancer, of any cancer, is chemicals. And certainly there are chemicals in pesticides and herbicides. Now, nothing has been definitively linked in terms of our dietary intake to a specific kind of cancer. But the more that our bodies are exposed to compounds that may be not natural, we know that this can raise our cancer risk. The biggest thing, though, is that we have to keep in mind that cancers of all descriptions are primarily illnesses of aging. And as we are living longer, because we are keeping our diabetes under better control, our high blood pressure under better control, and we're not having as high mortality from heart disease, cancer has more of an opportunity to develop, because it is a disease of aging, because over time, whether it's the sunburn and the radiation that you had when you were a kid, or whether it's the chemical exposure or even some viruses, eventually these damages build up and we simply can't repair all of them. So I can't say that our food is giving us cancer, but I would say that certainly we know that if we can minimize chemical exposures, we're likely to have less damage over time.
Thank you. Okay, this one, again, Dr. North, I'm going to put it to you because it's in regards to the tumor suppressor genes. Is there an easy way to test for the tumor suppressor genes, and should children of patients be tested?
So I think the issue about testing for tumor suppressor genes, there's whether you should or shouldn't, or do you have to, and then the practicality. We have identified just a few number of genes in kidney cancer, and the most common one in clear cell that we talk about is this von Hippel-Lindau gene. And yes, it can be tested for, and we can identify that in many people's cancers there are abnormalities of this gene. But what I pointed out to you is that most of those are sporadic or just bad luck situations. So that's why the family history is so critically important when you're being asked at your first doctor's visit about what do you know about your family's history of cancer. Because again, if you have a family history that would suggest that multiple family members all had kidney cancer and they were all 35, that is a very different story than the only person in the family who's got RCC is you, and you were diagnosed when you were 60 and there's no other cancers in the family. Those two stories would obviously be a very different scenario for whether you think that that family has an inherited problem. So you wouldn't send every kidney patient or every kidney patient's family members for genetic testing. What you would do is you would identify those strong family histories that you think there might be something there, and those would be the people where you would start off looking at the patient with the cancer to identify if they actually had a mutation of their genes or not. And once they knew what their status was, then it gets really complicated, because then it's an individual decision about who in the family wants to be tested, because there's lots of implications of genetic testing, and we don't have time to go into all of those, but that's where you really need a good geneticist and genetics clinics, because that gets really into a lot of medical legal gray zones and a lot of complications.
Great. Dr. Black, there's a couple of questions here in regards to kidney cancer follow-up and what's appropriate based on stage and grade. Could you just allude maybe a little bit to the guidelines and where we're at with those? And there are some copies at the back if people want them.
Yeah, so follow-up is often fairly nebulous, and everybody does it differently. But for kidney cancer, we do have the luxury of guidelines in Canada put together by a group of kidney cancer experts together with Kidney Cancer Canada, so that based on your stage and exactly what you have, it lays out exactly, chest X-ray at this time point and this point, and a CT scan at regular intervals and labs. So there's no one answer. It depends on exactly what you have. And the best thing you as a patient can do is get a copy of these guidelines, go to your doctor and say, here, this is what I want to do.
Great, thank you. Okay, this is for Linda. Okay, so Linda, this is someone who has a very heavy physical job and so needs a fair number of calories in their diet to keep up their energy level for the day. How can they eat low protein when protein tends to keep you full and for a longer period of time?
That's a really good question. I guess for people who do a lot of heavy work, the important thing is to, first of all, make sure that you do have snacks throughout the day. Frequent meals, your 3 meals and snacks in terms of protein. Have a protein at every meal because that stays with you. Even if it's a small amount of protein, just have some at every meal, and maybe even that snacks if you could fit them in, because that stays in your body longer and keeps you full longer. And then snacks, if you pick some of the grain snacks that tend to be more complex in carbohydrate, that may help stay in your body a little bit longer.
Great, thanks. Dr. North, can you briefly talk about the complementary therapies? Some of the people in the audience didn't really know what you were referring to.
Sorry. So complementary therapy or alternative therapy are medications or treatments that patients may be taking that, in Canada we might not consider to be Western medicine, quote unquote. So it was a lot of the Chinese herbals that some people are interested in taking, a lot of the supplements that can be purchased over the internet, and there's literally dozens and dozens of them. And many of these things are marketed as being immune boosters, or they're billed as being kidney tonics or liver tonics or whatever. And they're just not typical prescription type medications. And that's usually what we're referring to when we're talking about complementary or alternative therapy. And certainly in talking to a lot of my colleagues here in Vancouver, because of the population here, there's a very large number of people taking herbal remedies that come from the Orient. And some of those are very biologically active. In other words, they can cause liver and kidney irritation, and there's real substances in them. As a chemotherapy doctor, I can tell you that traditional chemotherapies that we use are built around natural plant products. And so there's no question that these are active agents. The problem is we just don't know how they might interact with the usual prescription type medications or other therapies that we might be using that we consider to be, for lack of a better term, standard.
Okay, great. Time for a couple more questions. Dr. Black, if someone has a positive margin in their pathology report after a partial nephrectomy, should they be going on to have an immediate radical nephrectomy, full nephrectomy? Or should they just be monitored closely with imaging?
Yeah, so the clear answer there is no radical nephrectomy. We know that margin status for partial nephrectomies is not as critical as it is for a lot of other cancers. It depends a little bit on the tumor. Again, these are often very small tumors. If it's a 3 centimeter tumor with a positive margin, the risk of that tumor coming back is very small. If it was an 8 centimeter tumor and somebody's pushing the limits, then that positive margin might mean something different because it's biologically a more significant tumor. So the easy answer is no, you don't get a radical nephrectomy, and you don't necessarily even get followed more closely. I think ultimately you're going to want to be followed a little bit more closely, and your urologist may order imaging a little bit more often, but positive margins at the time of partial nephrectomy are not uncommon, and there's very good evidence that it doesn't make a big difference.
Thank you.
I'd also add that positive margins can mean a lot of different things. A lot of it's artifact of how the tissue is processed when it goes to the pathology lab. We sometimes cut into tumor, recognize it, back off, find the right plane, and get around it. As far as the pathologist is concerned, that's a positive margin. As far as we're concerned, we clearly removed everything. So.
Okay. Dr. North, if the diagnosis is incidental, could there be higher numbers of RCC than are reported in the literature?
I think this comes back to the fact that we've seen incidence rising over time, and it is probably in part this overdiagnosis. And what we're seeing is once you've diagnosed a problem, people feel compelled to do something about it. And that's what Dr. Black was mentioning, that we've got a lot of these incidental renal masses now. So one of the issues is that it could be an artifact of why the numbers look more on paper, so we're just diagnosing more, but the people have always had these cancers, we just never knew about it. The other thing is that the technologies that we have to do medical imaging nowadays are a whole lot better than they used to be. So the CAT scanners of 2013 are not the CAT scanners of 1995, 1996, and they can find lots of stuff that we never knew was there before. So it's a problem not just in renal cell carcinoma, but all across cancer.
Okay, great. Thank you so much. I am hanging on to the questions that we weren't able to get to in this question period, and if we have time in the one this afternoon, I'll keep those for.
Okay, so
Dr. Black has one more.
The patient asking about the lymph nodes, I'd be happy to talk to them at the front if they want to afterwards.
Okay, great. Thank you.